Are you able to see my screen?
Yes, sir.
This is your exam syllabus, okay? I will share this paper with you in the groups. So we need to complete this syllabus for the CCS exam, guys. Whatever we covered up to now, book leadings and all guidelines, but we need to complete this syllabus to clear the exam. Okay. So one question concept we can discuss. Whatever concepts you know, you can tell me. Whatever you don't know, we can discuss. Okay. So first domain one, coding knowledge and skills. Here first concept, assign the diagnosis and procedure codes based on the provider documentation in the health record, which means you are able to find the diagnosis and procedure codes in the document in the question, right? You can able to find the diagnosis and procedure code leading. It was possible or difficult to identify the diagnosis and procedure ICD, CPT,
Possible.
PCS codes.
It's possible, Shiva.
You are possible, right? You can able to find the
Yes.
diagnosis and procedure codes. No?
Yes,
Next,
yes.
next concept. Identify principle or first listed diagnosis and procedure based on the respective guidelines. Okay, in the document, how we need to identify the principle or first listed diagnosis? We can discuss. Principal diagnosis means PDX shortcut, okay, or first listed diagnosis. While we are working in the exam point of view or regular coding, diagnosis coding sequence was very important, okay. Diagnosis coding sequence was very important. We need to follow the diagnosis sequencing. While arranging the multiple diagnoses, we need to follow the sequencing. Sequence was very important in the exam point of view. If you know the codes, it was not useful. We need to follow the coding sequence also. Sequence లో కోడ్ చేసుకోవాలి, ఓకేనా? We need to follow the sequencing of codes. So first, which diagnosis we are giving in the sequence first on the top, that diagnosis should be principal diagnosis or first listed diagnosis. Remaining diagnosis should be secondary diagnosis. Okay, while we are working on the secondary diagnosis, we need to assign first MCC conditions, then CC conditions, then diagnosis, Z series codes, external cause codes. In this sequence, we need to arrange PDX, MCC, CC, diagnosis, Z series code, external cause code. But exam point of view, we need to find the PDX enough. SDX, no need to follow the sequence. Secondary diagnosis, if you identify in the record enough for the exam, we need to find the principal diagnosis compulsory. So what is the principal diagnosis or first listed diagnosis? Anybody have idea PDX means?
Presenting condition.
Reason for
Patient admission.
Patient admission. Presenting condition.
reason for admission.
Reason for it.
Reason for the admission. Try some more.
Sir,
Patient
the
will be coming with the symptoms. After based on the symptoms, they will be conducting some diagnosis tests and all. Physician make a decision on that and come to a conclusion, underlying cause of that symptoms. So that will be the PDX.
Correct, bro. Reason for the admission related, established diagnosis. Okay. Reason for the admission related, established diagnosis should be the principal diagnosis. Reason for the admission, not PDX. Suppose patient coming with particular symptoms, reason for visit. Example, I am saying assessment. Assessment. So what is the principal diagnosis here?
Asthma.
Asthma.
Asthma. Cough we can code as secondary diagnosis.
Yes, we can.
No.
It will be a symptom.
No, it is a
Even
symptom.
when the established diagnosis found, condition related symptoms no need to code. Okay, condition related symptoms no need to code. When you are coding the condition, that condition related symptoms do not code, but unrelated symptoms we can code. Suppose patient coming with cough, assessment they given asthma, leg pain. Now how we can code?
Leg pain. You need to
Leg
put
pain
the-
can we code or not?
Yes.
We can code.
Leg pain considered as SDX,
Yes,
correct?
yes.
Past medical history have diabetes. Medication they given insulin.
Now we
Now
can code diabetes also.
and SDX. What is the PDX here?
Asthma.
Asthma.
Asthma should be the PDX. Then
Leg pain.
79609.
70969.
Whatever, I will type the condition.
Okay.
J4.
45909. No? Then diabetes.
11.9.
Long term is of insulin. Long term is of insulin medication. Like this, we need to code. Cough was the symptom of asthma, so we should not code the symptom. Okay. When the reason of the admission related established diagnosis was found, that established diagnosis should be the PDX. Next concept. If the established diagnosis not found, patient coming with symptom, assessment also they documented symptom. Then
symptoms coach.
Symptoms. We can code.
what is the PDX then?
Cough.
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 Only cough should be the PDX. Cough R059.
Yes.
This is the PDX. Next, when the patient coming with symptom, they documented unrelated diagnosis. And symptom. Then what is the PDX? Unrelated diagnosis they found and they written in the assessment along with symptom. Now what is the PDX?
Unrelated condition they given as assessment, Shiva Garu.
Yes.
Yes, we can go with the unrelated one, no? Because that one is the more severity, no? Comparatively.
No.
Okay.
Whatever the symptom only PDX. Okay.
Okay.
Reason of the admission related only we need to check. If they found 5 to 6 assessment diagnosis they mentioned, but all are unrelated to the reason of admission, then symptom only PDX. Do not go with diagnosis if it should be unrelated to the reason of admission. Always look for the reason for visit related only. Okay, what is the reason they admitted? If they admitted with symptoms, that established condition found, established condition should be PDX. If they're not found, symptom only PDX. What is the reason they are admitting? Okay, va?
Okay.
Cough only PDX. Then gastritis should be SDX. Okay, next. Suppose patient directly coming with the diagnosis. There is no symptom. Directly they admitted for the diagnosis, treatment of diagnosis, and they treated the diagnosis. At that time, the particular diagnosis only PDX. For which condition they are admitting, the diagnosis only PDX. Okay, no? Directly they admitted for the treatment of condition, not symptoms. For which condition they are admitting, that only PDX. Okay, va? If they are admitted with symptoms, okay, if they admitted with symptoms, check established diagnosis found or not. If the established diagnosis found, reason of the admission related, symptoms related, condition found, that condition should be PDX. Do not code the related symptoms. Then there is no established condition, then symptom only PDX. Suppose patient admitted with diagnosis and they treated the diagnosis, then the particular diagnosis only PDX. Clear?
Yes.
So can you go with the other example?
Any example you can take, same thing. Next concept. Suppose patient coming with SOB. Okay. Assessment documented, pneumonia, chest, CHF. Then which means more than one established diagnosis found, reason of the admission related, multiple diagnoses they find. For these two diagnoses, SOB was the symptom, right?
Yes, sir.
Shortness of breath, symptom for CHF and pneumonia. Now, when the two or more established diagnoses meet for the definition of PDX, two diagnoses support for the principal diagnosis. At that time, look for the DRG value. Okay, when more than one diagnosis meet for PDX, look for DRG value. I will explain later. Remember, look for DRG value. As of now, note down the DRG value. Look for the DRG value. Which condition have highest DRG value? That diagnosis should be the PDX based on DRG value. Which diagnosis have highest DRG value? That should be the PDX. Next, if the both diagnoses have same DRG value, both diagnoses have same DRG value, any one diagnosis should be the PDX. If same DRG, both are meet for the definition of PDX. Any one you can give the PDX. Clear? Any doubt up to now?
No, sir.
Then,
No.
then.
Bro, I will
Everybody understood,
explain.
right?
If the patient is came for the
Tell me.
fracture
Mm.
and they have symptom which is leg pain and the
Mm.
fracture is on left hand.
Mm.
So the provider treated for left hand fracture. So
Mm.
PDX is left hand fracture, right?
Correct. That's it.
Sir, I have a doubt, sir.
Yeah, ask. No doubts, most welcome.
Yes, sir. It's a different scenario. Like, if a like patient have a stroke-like symptom and he has been diagnosed means as a stroke, we would code the stroke and also the symptoms of the stroke, like either patient have dysphagia or like that, etc. Sir.
Actually, no.
So how?
Yes, 1 minute. For the neurological conditions, right, like CVA, we need to code the symptoms also for that particular diagnosis. Not for all the diagnosis. For neurological disorders, we need to code the related symptoms also. We need to code stroke related symptoms also, like only not all the symptoms, only neurological symptoms like dysphagia, aphasia, these type of symptoms we need to code. Okay.
Okay, sir. But I like, what is the guideline for this, sir? Like any extended treatment like that we have to consider like that, sir.
Not like that. If you found any neurological symptoms, we can code, no problem, along with stroke. Only for
Oh.
stroke, we need to code only that also, not all the symptoms of CVA. Only neurological symptoms we can.
Okay, sir. Thank you so much.
Bro, the end concept is the workup which is going for more, that should be the PDX, right? The provider which have taken more workup, so that should be PDX.
That only, no, for which diagnosis they will do more workup. The reason of the admission related established diagnosis only they will do more workup, right?
Yes, so that will be the PDX, right? If the
That
patient
only.
has come for something else and they have treated for the other thing, and then that should be the PDX,
No,
right? Which is
no.
for
What is the reason they are coming? That only PDX. If they treated other thing also, we should not go with the other thing. What is the
Okay.
reason they are coming? That only PDX.
Okay. Thank you.
Next concept, burns. When the patient have burns, code highest degree burn first. Highest degree burn PDX. Next, pregnancy. Always O series should be sequenced first. Multiple injuries. Patient have multiple injuries like fracture, laceration, dislocations, contusion, abrasion. How we need to code, no? Code first most severe sequence fractures, okay? Fracture should be sequenced first. After the fractures, dislocation, laceration, strain, contusion, abrasion. In this sequence, we need to, when the patient have multiple injuries. Suppose if the patient have multiple fractures, code most severe fracture should be sequenced first. When the patient have multiple fractures, code most severe fracture should be sequenced first. Clear? This guideline everybody know, right, guys? When the patient have same site, most severe injuries and superficial injuries like contusion and abrasion, we need to code only most severe injury, correct?
Yes, yes.
Yes, sir.
That guideline everybody remember, no? Suppose
Yes.
on the same site they documented face laceration, face contusion. What we need to code?
Laceration.
Only face laceration enough. Contusion not required. Suppose if the different site, how we need to code the sequence? Suppose patient have face laceration, scalp contusion. Then what is the PDX?
Face laceration, sir.
Last section.
laceration, then SDX should be contusion. Like this we need to go. Okay.
Sir, fractures లో కూడా displaced, non-displaced.
When they not mentioned displaced or non-displaced, default what we need to code? Displaced.
కూడా అంతే కదా సార్ డిఫాల్ట్
They didn't mention anything.
If they not mentioned either displaced fracture or non-displaced fracture, just they mentioned fracture.
Displaced, Shiva garu.
Yeah, displaced fracture we need to code.
Yeah.
That only
same
I
goes
know.
with open or closed also, right sir? Closed.
If they not mentioned open or closed, default go with closed. So default should be closed. If fracture is not indicated as open or closed, should be coded as to closed. If fracture not indicated whether displaced or not displaced, go with displaced. Clear?
సార్ ఇందాక డిఫరెంట్ సైట్ అని చెప్పారు కదా సార్ అది
ఏది
ఒకసారి చెప్తారా ఎగ్జాంపుల్ డిఫరెంట్ సైట్ ఇది కాదు సార్
అది ఏం లేదు. సో గుర్తుపెట్టుకో, when they given the multiple injuries, okay, same site means do not code the superficial injuries like contusion abrasion if they documented along with contusion abrasion and most severe injury. For example, face contusion, face laceration, they documented. What we need to code?
ఫేస్ లాసరేషన్
Only laceration. Then suppose in the different sites they documented, not same site. Face laceration, scalp contusion. Then we need to follow the sequence. Laceration first, then contusion. We need to code all the diagnoses if they documented different sites in this sequence manner.
ఓకే థ్యాంక్ యూ.
Next, poisoning means always poisoning should be PDX. Adverse effect, how we will code PDX?
We should not report as a PDX.
What we need to give the PDX? Nature of effect. Okay.
Yeah.
What effect developed due to that particular medication? Nature of effect, then adverse effect of drug. T series here, not PDX. SDX. Adverse effect of drug should be the secondary diagnosis. Clear? Adverse effect means patient took properly medication. Okay? Properly administered. Suppose patient prescribed 100 mg. Patient took also same route of 100 mg medication, but due to the medication developed side effects. Adverse effect means side effects of the medication. Properly prescribed, properly administered, but it was showing some reaction in our body. It called as adverse effect, adverse reaction. For some people, penicillin was not suitable. Na? If they take penicillin, they will get the rash on the body and all, right? That should be the adverse reaction. Poisoning means overdose. Okay. Taking the more dose than prescribed dose. It should be poisoning. Properly prescribed, properly administered, adverse effect. So when the adverse effect documented, go with nature of effect first. What effect developed to the patient? Then we need to code adverse reaction. Clear?
Okay.
These are the selection of PDX, guys. Now you get idea, right, how to select the PDX and all. So maximum reason of the admission related established diagnosis, you need to pick P. In the case studies and multiple choice questions, sequencing first, PDX should be most important in the exam. Okay. Then we have some cause and effective related and combination codes, right? That combination codes look for always sequence first. Suppose DM complications, what we need to give first? Okay, what we need to give first?
E1122, sir.
Okay.
E
So always
11.
E series code, okay,
along with
diabetic
that
complication should be PDX. Suppose patient have coming with ESRD and they treated ESRD, past medical history have diabetes. What is the PDX?
Diabetes combination code only, sir.
Even
Yes,
though
sir.
DM documented in the PMH, still we need to go with 1122 only. We should not give the sequence ESRD first, okay, when the patient have diabetes or hypertension. Okay, when the documented hypertension also high 1-2 series. When the patient have hypertension, CHF, CKD, in these three also, code first hypertensive combination code I11 series, I12 series, I13 series. Then only ESRD or CHF or CKD. Clear? Do not code CHF first, then hypertension CHF, I110 second. It was wrong, okay? Code I11 series, then CHF code. Clear? This sequence should be most important while you are working on the combination codes. Got it? Still any
Yes, sir.
doubt? Sequencing of diagnosis. Whatever you have doubts, you can ask me, guys. Doubts are most welcome. But do not tell me after completing all your exam, I didn't get a single question what you said like that.
సార్ జెడ్ కోడ్స్ కూడా ఒకసారి చెప్తారా?
Jet codes, which sometimes we need to give the PDX. Jet codes depends on that. For like long-term use of medication, status codes and all, we need to go with SDX. Some Jet series codes encounter for the examinations, place and type of birth, we need to give the PDX. Okay, like history diagnosis, some personal history, family history, long-term use of medication also will get in the Jet series. That all we need to give secondary diagnosis. Only for screening diagnosis, encounter for the screening of mass colonoscopy, mammogram, or encounter for observation, suspected or routine encounter screenings, and newborn, okay, type and place of birth, Jet 38. This we can give the PDX.
హిస్టరీ లాగా ఇస్తే సెకండరీయా సార్?
అంతే కదా.
ఓకే సార్.
Clear? History, long-term use of medications, secondary. First two concepts clear? Next, apply coding convention guidelines on regulatory guidance. Coding conventions means in ICD coding we have the sequencing conventions, right? Code also, use additional code, code first, and with, say, parenthesis, bracket, semicolon. These are the conventions. Before starting the chapter 1 specific guidelines, we discuss the coding conventions, right? Everybody will get the coding conventions, right? For working, you will follow the coding convention rules, right?
Yes.
Yes or no? We need to
Yes,
follow.
we are
Suppose,
following.
what is the meaning of code first means?
Before assigning the diagnosis, we need to code first.
Yeah, whatever they give in the code first, that diagnosis we need to give the first before assigning the diagnosis. For example, they documented anemia due to neoplasm. Go through the D63.0 in the tabular list ICD code. Here they will give clearly code first neoplasm, correct? If you go to the tabular list of particular code, you will get code first neoplasm. Everybody know ICD guideline leading, right? ICD code leading.
Yes.
Yes, right. D630 here. They given C. Code first neoplasm. Okay. Which means we need to code first neoplasm, then D630. We should not code D630 first, then neoplasm. Okay. First always neoplasm, then D630. Code also means if they mentioned code also means we need to
Means that
code that
additional code
diagnosis
that also.
that also we need to code. Okay. Code also means that also we need to add. Code first means that diagnosis we need to code first. Exclude one, exclude two, this and all everybody know, right?
Yes.
Exclude one, we should not code it here. Exclude two, we can code, not included here. When the diagnosis found on exclude one, we should not code the two diagnoses together. Exclude two, we can code. Next. Clear, right? Coding conventions, everybody know, right? Who don't know, please tell me, guys, if you don't know means coding conventions. Next. Attach CPT or HCPCS modifiers to outpatient procedure services. Everybody know modifiers, right? CPT modifiers. Yes or no?
Yes.
Already we discussed the CPT modifiers now. Yes, right. CPT modifiers we discussed, right? Always already.
Yes.
Yes.
Note down the exam related important modifiers, guys. These are the exam related important modifiers. Based on these modifiers only we'll get the questions. In these modifiers, anybody have doubt?
So FATA.
Finger modifiers.
Okay.
FA to F9, TA to T9, TA to T9, two modifiers. Total 10 na? FA to F9, TA to T9. RTLT
51,
late
52, 59.
modifier.
51, 52, 59.
51, 50 modifiers completed or not for you?
Yes, sir. But
What is the 51?
Multi.
Multiple procedures. When they're done, multiple procedures, it should be 51. 52, reduced service. Reduced means they perform the lesser service than the CPT description. They done the lesser service than the CPT description. For the 52 modifier, note down this concept, guys. You will get one question in this concept. This concept, note down for the 52 modifier. This is the 59. Different operative session, same date, different procedure, different atomic. $59 should be distinct procedural service. $50 should be
Bilateral procedure.
bilateral. Same procedure repeated on the both sides. 73, 74.
After anesthesia and before anesthesia.
Discontinued outpatient service. Discontinued the outpatient service prior to anesthesia administration. Discontinue the outpatient service after anesthesia administration. In this concept also you will get the questions.
In the last line, in the last line, you mentioned like append 52 modifier for unilateral services. What was the meaning?
Which means actually tonsillectomy and adenoidectomy procedure description, CPT description in the CPT book described bilateral. There is no separate code for the unilateral tonsillectomy, but they done unilaterally. At that time, what we need to do? We don't have unilateral separate procedure code, so we need to code that particular bilateral procedure code, and you need to append 52 to reduce the service. Whenever they performed tonsillectomy and adenoidectomy unilaterally, we need to append 52. If they're done bilaterally, do not append 50. Already bilateral was included in the CPT description for this procedure.
So any procedure which is mentioned as bilateral, but they are performing as a unilateral means we need to append 52.
Correct. Any procedure, CPT description documented bilateral. There is no unilateral code. Okay. At that time, what we need to do? We need to append 52.
Sir, question lo istara unilateral service.
Question they will give like how they will give. No, I will show.
Shiva, can you show in CPT book modifiers where it is?
You will open the first page. You will get the CPT modifiers. Turn the first
No, Shiva,
sheet.
2026 book they're not mentioned.
In original book, have you checked?
They have given Appendix A for the modifiers in 2026.
Yeah, in appendix you will get, and original book have you checked? You don't have in original also?
Yeah, it has, sir.
In original book we have in the main sheet. Okay, maybe in the PDF we don't have, but in the original book if you check you will get in the main sheet only. If you check original book 2026 also we have for the main sheet. I checked actually.
Reduce services అనే ఉంది సార్.
అర్థం కాల?
Reduce services అనే ఉంది సార్ 52.
You need complete description you are asking.
లేదు
all modifiers
బుక్ లో ఉంది అని చెప్తున్నాను సార్.
అదే. So if you people need detailed description of the CPT modifiers, you will go to the contents. In the main sheet, they will give just definitions. If you need detailed description of modifiers, You need to go for the appendix. Go to the contents in the first sheets, you will get which page you will get the modifiers. Suppose this is CPT book. Actually, in original book you will get, guys, here missed, leave it. If you need detailed description also, here you will get in the appendix A modifiers. If you go to here, you will get all the details. All the modifiers you will get there. Clear? With explanation, everything you will get here. These modifiers noted. You will get the question like this, guy. What is the 11-year-old boy present to the hospital with unilateral tonsillectomy? What modifier you will assign the code?
52.
52.
If you don't know the 52 also, you will get all the options, right? Go to the option wise. 50 bilateral, 51 multiple services. We should not code because they done single procedure. 59 also distinct procedure. There is no multiple procedures. That also eliminate. Like that also we can do the answer. Remaining 52 only. Clear, right?
Sir, in this case, they didn't mention that it was reduced service. Then how can we go with the 52 modifier?
They given unilateral tonsillectomy, right?
Yes, 50 is not applicable. 51 also not applicable because they done one procedure. 59 also not applicable. So we should data. Hello. So we should go like
Yes,
that.
tell me, bro.
Like we should go like that only, yeah.
That's it. Otherwise also, tonsillectomy and adenoidectomy procedures, I said now only. These are bilateral services. These are bilateral services. Do not append 50 modifier. If they performed bilateral, unilateral tonsillectomy, append 52.
క్వశ్చన్ లో క్లియర్ గా మెన్షన్ చేస్తాడు కదా సార్ బైలేటరల్ అని యూనిలేటరల్.
Yes, that only I am showing the question. Now same question you will get like this. This is the question in exam like this only will get.
It mentioned bilaterally go for 50, right?
No need to append 50, madam. That only I am saying, no. See, do not append 50 because this course description itself included the bilateral. If they mentioned tonsillectomy means it was a bilateral. Okay. Whenever they mentioned unilaterally, we need to append 52. If they not append mentioned unilateral, it should default bilateral. Clear? Huh? Got it? Or any confusion still? అర్థమైందా అండి?
Yeah, still confusions.
ఏంటి చెప్పండి మీ కన్ఫ్యూజన్? మీకేం అర్థమైంది చెప్పండి, నేను క్లియర్ చేస్తాను.
Okay, tonsillectomy and adenoidectomy, it give the bilaterally. We in questions they mentioned unilaterally give the we append the 52 modifiers, or else then it how can I identify the bilateral procedure?
If they not mention anything, it should be bilateral.
ఓకే, యూనిలాటరల్ అనేది మెన్షన్ చేయకపోతే బయలాటరల్, అప్పుడు 50 మోడిఫైయర్స్ ఇవ్వాలి అంతే కదా.
ఇక్కడ ఏం రాశానండి? Do not append 50, right?
యా సార్, క్వశ్చన్లో ఎలా ఇస్తారు అనేది.
క్వశ్చన్ లో అసలు మాడిఫైర్ 50 అవసరం లేదు. ఆ సిపిటి డిస్క్రిప్షనే బైలేటరల్ ట్రాన్స్లెక్టమీకి. క్వశ్చన్ లో ఎలా ఇచ్చేది మీకు అనవసరం. మీరు కాన్సెప్ట్ వినండి, క్వశ్చన్ గురించి ఆలోచించకండి. యూనిలేటరల్ అని చెప్తే యూనిలేటర్ 52 ఇవ్వండి. అసలు ఏం చెప్పకుండా ట్రాన్స్లెక్టమీ అంటే ఒకటి సిపిటి కోడ్ చేసి వదిలేయండి. 50 అనేది అపెండ్ చేయకూడదు అని నేను చెప్తున్నా. బైలేటరల్ అని చెప్పినా కూడా 50 అపెండ్ చేయకూడదు, బికాస్ దట్ సిపిటి డిస్క్రిప్షన్ సేస్ ఇట్ వాజ్ ఎ బైలేటరల్. గాట్ ఇట్?
ఇచ్చినా ఇవ్వకపోయినా మాత్రమే 50 మాడిఫైర్ అపెండ్ చేయకూడదు, అంతే కదా సార్?
అంతే అండి. యూనిలేటరల్ అని చెప్తే యూనిలేటరల్ వర్డ్ కనపెడితే 52 ఇవ్వండి. యూనిలేటరల్ వర్డ్ లేకుంటే జస్ట్ సిపిటి కోడ్ చేసి వదిలేయండి. రిమైనింగ్ ఆల్ క్లియర్?
సార్ ఇది ఓన్లీ ఇది రెండిటికేనా సార్?
Yes,
సార్
only
ఈ
for
2 ప్రాసెసర్స్ కే
guideline
50
for this.
మాడిఫైర్ ఇవ్వకూడదు. ఈ 2 ప్రాసెసర్స్ కే 50 మాడిఫైర్ ఇవ్వకూడదు, అంతేనా సార్?
అంతే అండి. ఈ రేంజ్ అండి, ఈ రెండు కాదు, 4810 అండ్ 42830 బిట్వీన్ ఐఫోన్ పెట్టారంటే దీని మీనింగ్ ఏంటి? రేంజ్ కదండి. కామా పెడితే ఆ రెండు కోడ్స్, ఐఫోన్ పెడితే ఏంటి? ఆ రేంజ్ అని కదా.
ఓకే సార్.
ఈ మాడిఫై ఇండెక్స్ లీడింగ్ లో ఉంది కదండి. ఐఫోన్ మీన్స్ వీ నీడ్ టు చెక్ దట్ రేంజ్, కామా మీన్స్ దట్ పర్టికులర్ కోడ్. Next, any doubt in the particular modifiers XE, XS, XP, XU? Everybody know?
Yes.
No, sir.
In this concept also one question you will get, okay? Next, determine appropriate sequencing of diagnosis and procedure code based on the scenario. You know the sequencing of diagnosis, right? What we need to code first and what is the second. We have some sequencing rule PDF now. I will share the sequencing rule PDF. Who don't know the sequencing of ICD code, follow the sequence rule. Who are already working, you people are following the sequencing, right?
Yes.
We are
Yes.
following the sequence.
Yes.
That should be the sequence.
Sorry, sir, but we don't have that knowledge regarding the sequencing.
I am sharing the PDF. Go through the sequence rule PDF. In this, we have all the sequencing guidelines from all ICD related. When the have multiple combination, which code we need to give the sequence first. Okay, I shared one PDF now. Check sequence rule. If you read this PDF, enough. Okay, this PDF should be enough for the sequencing. Clear? Huh?
Yes, sir.
For slow track, already ICD completed, so you already know the sequencings. Next concept, apply present on admission guidelines. Note down present on admission guidelines, POA guidelines in short form. Present on admission guidelines, in short form, POA.
Present on arrival.
I didn't get you. present on admission guidelines, POA short form. We can discuss these guidelines. In this concept, you will get 2 multiple choice questions, guys. POA. POA, present on admission guidelines, we need to use for ICD-10 CM codes only. We need to append only for the ICD-10 CM codes in the inpatient coding. While we are working in the IPDRG, we need to follow these POA guidelines. While we are working in the IPDRG, we need to follow these POA guidelines. We need to append for the ICD-10 CM codes only, which means only for the diagnosis codes, not for the procedures in IPDRG. Next, POA means present on admission. Admission ante enti? What is the meaning of admission?
At the time of admission.
When the patient is admitted.
Joining in the hospital. Admission means joining, correct?
Yes.
Or admitting. So admission at the time of joining or admitting in the hospital. That should be the admission. So here, first thing check. Admission in hospital means which hospital? Inpatient hospital. As inpatient. Admitting as inpatient. So if you go to the any hospital, directly will get IP admission?
No.
No.
No. How we need to go first?
Emergency.
If this means emergency department, then
OP, then
office visit, right? OP, office visit. Then observation department. And outpatient services, same day surgeries. Outpatient procedures, same day surgery. You plan for the outpatient surgery, they done the surgery, but due to the surgery, some complication developed. Due to the complication, you are admitted in the hospital. Outpatient surgery, same day surgery also. Okay. Based on this visits, if you go to the hospital, due to the patient condition, physician will give the admission or they will discharge on the same date. Correct?
Yes.
If you go to the hospital with any particular diagnosis, physician will check the patient. Then physician will decide whether they want to admit or they want to discharge same day. If they discharge the same day, it should be considered as what type of visit?
Outpatient.
Outpatient. If they are admitted and if the patient stays more than 24 hours in the hospital, consider as
Inpatient.
Inpatient.
So these are the outpatient visits. This is the note down: ED, emergency office visit, observation, same day surgery. IP admission time. From that time only patient consider as inpatient. So when they got the inpatient admission, from that minute only patient consider as inpatient. Before getting the IP admission, patient was stays in the hospital. Still the patient consider as outpatient. Okay, na IP admission వచ్చాకే patient inpatient గా consider చేయాలి. Before getting the IP admission, patient still in the hospital, but we need to consider as outpatient. Do not consider as inpatient. Suppose you are going to the hospital, you are in the hospital, you are waiting for the meet the physician, you are sitting in the chair, suddenly fall from the chair and developed knee contusion. It was developed before admission or after admission?
Before admission.
Before admission. Still it was in OP only, right?
Yes.
So first look for that. Okay, when the diagnosis developed, before admission or after admission, that should be important. When the diagnosis developed to patient, before IP admission or after IP admission. For this only we are using the POA guidelines, guys. Present on admission means what are the diagnosis present on admission and what diagnosis not present on admission. Okay, well? What are the diagnoses developed to the patient at the time of present on admission, inpatient admission? What are the diagnoses developed after inpatient admission or not present on admission? Based on for that, we are using the POA guidelines. When the diagnosis developed, to identify the particular diagnosis when they developed, we are using POA indicators. I shared one PDF in the group check. 6 pages PDF. This PDF I shared na present on admission reporting guidelines. So we have total 5 indicators, guys. Note down these indicators: Y, N, U, W, and E. E. Y, N, U, W, E. Y means present at the time of inpatient admission. What are the diagnoses present at the time of inpatient admission? For that all diagnoses we need to assign Y indicator. N, not present on admission. What are the diagnoses not present at the time of inpatient admission? For the diagnosis, we need to assign N indicator. Okay, not present on admission, which means which diagnosis developed in the inpatient admission, after inpatient admission, assign N. Who will assign the indicators to the diagnosis? Who will assign the indicators for the diagnosis?
Coders will
Coders. Coders will assign. While you are assigning the diagnosis, along with the diagnosis, you need to give the POA also. Then E means, E note down, for all Z series ICD code. For all Z series ICD codes, assign E. For all Z series ICD codes, assign E. For all Z series ICD codes, assign E. Clear? Then U means documentation is insufficient to determine if condition is present on admission. Documentation is insufficient to determine if condition is present on admission, which means if based on the documentation we are unable to find when the diagnosis was developed, before admission or after admission, there is no sufficient document when the diagnosis was developed in the record. If they not mentioned clearly when the diagnosis was developed, before IP admission or after IP admission, then what we need to assign? U indicator. Whenever we are assigning U indicator, we must raise the query for physician for the POA status. Because there is no sufficient document means we need to question the physician for the POA status. Okay. If you assign U indicator means must raise the query to physician. Do not complete the record. Pend for the clarification. Query for the physician. Now, physician also states, I am also unable to determine. Provider also unable to determine. Physician states, I don't know. Physician also unable to determine. Then W. Coder unable to determine U. Physician unable to determine W. If the diagnosis developed prior to inpatient admission Y, after inpatient admission N, all Z series ICD codes E, and unreported or not used means exempt from the POA. For this unreported or not used diagnosis, do not append any POA. Do not append any POA. Note down the exempt from POA list Q00 to Q99. What is this code range?
Congenital.
Congenital conditions. For this code range, no need to append any POA status. POA left blank. POA field left blank.
Sir, please repeat.
Whenever we are coding Q00 to Q99 diagnosis, do not append any POA. These are the exempt from POA list. POA field left blank. Okay?
But with Z codes, we are appending E, right?
Yes.
Okay.
For all Z series, E. Do not check when the diagnosis develops. If you see Z series ICD code, append E. Noted.
What was the definition of EA here?
E status.
Like YNWW. Is there a
No definition. That only I am saying. No, there is no definition. E means all Z series status codes. Whenever it was developed. Whenever the diagnosis is developed, when we need to append for all the Z series ICD codes. Only for Z series ICD you need to use E. Next, note down time frame for assigning the POA. Time frame for assigning the POA. There is no required time frame. Time frame to assign the POA. There is no required time frame to assign the POA. Time frame to assign the POA. No required time frame to assign the POA. There is no required time frame. No required time frame. Clear? So next, guys, when we need to assign Y indicator, first note down. Y indicator when we need to assign. For all chronic conditions, identity.
When the condition is present on the admission.
Yeah. That only I am saying. When we need to assign, no, for all chronic conditions, assign Y. Chronic conditions means what is the meaning of chronic?
Long-term conditions.
Conditions that have existed more than 6 months.
So that which means that chronic condition present from past, right? So it was present at the time of admission. So default chronic condition Y. No need to look for the chronic conditions when it was developed because chronic itself long term. Okay. Prolonged services. So prolonged services should be the chronic. So it was already present from the past. So always Y indicator. Then all neoplasms. All neoplasm. Cancers also assign Y. Because cancer will not develop in a single day. Correct? We can't able to find even cancer when it was developed. We need to take the biopsy path report and we need to check for that pathology report and we need to identify it was whether neoplasm or not. So all neoplasms Y. Okay. Reason of the admission related established diagnosis, which means principal diagnosis Y. Reason of the admission related established diagnosis also Y. Reason of the admission related established diagnosis also Y. Because if you go to any hospital, you will tell your symptoms or you will tell you directly the condition to the physician.
Symptoms.
Symptoms, right? If you go to any hospital, you will tell I have headache, stomach pain, leg pain, fever, cough, shortness of breath. Then what the patient will do?
Exam,
Say
physical
the
exam.
main.
Huh?
Physical examination.
Physical exam. They will examine the patient then. After
Lab orders.
examination, what they will do?
Lab orders.
They will do some diagnostic workup, right? Either laboratory or X-ray or something. They will do the diagnostic workup, right? What is the reason of the symptom? They will identify, right? If you
Yes.
go to the hospital with fever, what they will do? They will do blood test, right?
Yes.
Yes. Why? Because they need to identify the reason for which reason they got the fever. Suppose if you go to the fever, they done the blood test and they identified you have malaria. So now tell me, malaria was developed in the hospital or already patient have malaria? Already patient have malaria. It was identified after admission in the hospital. Condition was clearly present prior to admission, but it was diagnosed after admission. Correct?
Yes.
Condition clearly present before admission, but it was diagnosed after admission. It was not developed. Here, diagnosed different, developed different. Develop means newly develop the diagnosis. Here, just diagnosed, identified the disease. So, Y indicator. Okay, suppose you go to the shortness of breath and they had done the chest X-ray and they identified the CHF. So, you need to append Y indicator. Clear?
Can you say again repeat once? Once again, last repeat. Last one.
Any diagnosis. Okay. Reason of the admission related condition. The condition diagnosed during the admission or after admission but clearly present before admission. Condition was patient have clearly before admission but they don't know. They had go to the hospital after identification, after diagnostic workup, they find the diagnosis. But the diagnosis already present prior itself. For that diagnosis, what we need to assign? Y indicator. If you go to any hospital with particular symptoms, after diagnostic workup, they find the disease. For that disease, what we need to assign?
Y indicator.
Y indicator. Next note, the conditions develops during outpatient encounter prior to inpatient admission, which means you patient was in the hospital like emergency department or same day outpatient service or observation. In that period, diagnosis was developed. Then they admitted in the inpatient hospital. For that diagnosis, what indicator we need to assign? If any diagnosis developed in emergency department or outpatient services and all.
No indicator because POA is for inpatient diagnosis only.
Huh?
Why, sir?
Why indicated?
Y indicator we need to assign.
In ED office or observation, we do not append POA, right?
What I'm saying,
Hmm.
diagnosis developed in ED.
Okay.
Then they admitted in the inpatient.
Okay. Then why indicator?
Condition diagnosed in outpatient. Then they admitted in the inpatient.
Okay.
So we need to assign Y indicator. For example, see this first question.
Y for fracture and CHF.
Y for fracture and CHF. Because fractured in emergency department, then they move to inpatient admission. So what indicator we need to assign here? Y for fracture and
CHF.
CHF. Option B. Twentieth question.
A.
What is the answer?
A.
A.
Oh,
Why? Because atrial fibrillation was developed in the outpatient procedure. Then subsequently they admitted. Clear? Next concept. For newborns, by birth or during the delivery process. By birth or during the delivery process. If any diagnosis developed, we need to assign Y indicator. Okay? For newborns, by birth or during the birth process, like birth traumas, injury during the delivery, or exposure to strep B in the vaginal canal, or develop meconium aspiration, by birth or during the birth process. Clear? Next, note down when we need to assign N indicator. N diagnosed developed after IP admission. And we have some clinical concept here, guys. Course that contain multiple clinical concept. In these three scenarios, we need to assign N. Note down these three scenarios. Patient coming with COPD after admission, COPD was exacerbated. Patient coming with gastric ulcer after admission, it was bleeding. Patient coming with asthma after admission progressed to status asthmaticus, assign N. In these three situations, we need to assign N indicator. Note down these three. Noted.
Yes, sir.
Thank you, guys. Remaining concepts we can discuss tomorrow. Okay. One concept we can complete. We are going to discuss 6th concept. Up to 5 concepts you can prepare. Whatever you have doubts, you can ask me. I will explain. Okay. So POA we can cover by morning. Monday, not tomorrow. Tomorrow no class. Monday we can cover. So as of tomorrow, everybody read that sequencing rule PDF. Okay. You will complete
Yes,
the
sir.
5th concept. I shared the sequence rule PDF in the group. It should be 13 pages. If you read that 13 pages sequencing, enough for the ICD.
Okay, sir. Thank you.
Thank you, guys.